Thank you.
So now we welcome, the youngest ophthalmologist of AIOS, our ex-president, and sir is active in so many fronts that if I start talking about it, it'll probably take next 10 minutes. Welcome, sir.
Thank you.
We're talking on FFA, ICG, and AMD.
Yeah, thank you, Ajay. And so we all know that fluorescent angiography was introduced in ophthalmology by Novotny and Alves in the 60s of the last century. I'm glad that Dr. Patnaik introduced that in Delhi in the early 60s after his fellowship from Switzerland. And initially they used this technique in diabetic and hypertensive patients, and after the technique was used in ARMD. And FA is the most important ancillary test for classifying the disease in its different subtypes. And we know the dry AMD with hard drusen, soft drusen, focal hyperpigmentation, geographic atrophy of RPE, and the extent of the lesion. So here you see the drusen and RPE abnormalities. Several types of drusen can be identified. Hard drusen are small, less than 63 micron, round, well-defined yellowish deposits that correspond to accumulation of hyaline material in the inner and outer collagenous zones of Brooks membrane. On FA, they appear hyperfluorescent as transmission defects due to overlying RPE thinning. And RPE abnormality, just now both Shilpi and Prashant spoke. Focal hyperpigmentation is a risk factor for the development of choroidal neovascularization, and angiography appears as a blocked fluorescence, and histopathologically it is characterized by focal RPE hypertrophy and pigment migration into subretinal space, published by SPIC. And atrophic AMD, atrophy can occur in sharply defined areas of severe atrophy, known as geographic atrophy, or in less well-defined, more granular regions of less severe atrophy, known as non-geographical atrophy. And the angiographic appearance depends on the remaining pigment with RPE and choriocapillaries. And in the GA, typically shows late, well-defined hyperfluorescence from staining of the exposed deep choroid and sclera. In these cases, visual acuity depends on the foveal involvement. And here we have the wet ARMD, the classic, occult, and the RAP with the different types. And in the classic, you have characterized by well-demarcated hyperfluorescence in early phase of fluorescent angiography and late leakage that obscure the boundaries of the lesion. And angiographic classic CNV appears as a lacy or bicycle wheel pattern. And depending on its location, it can be classified as extrafoveal, more than 200 microns from the foveal center, and juxtafoveal 1 to 199 microns from the foveal center, or subfoveal involving the foveal center. And classic with the loculated fluid, the dye pooling is well demarcated in a confined space of a localized sensory retinal detachment or with intraretinal cystic spaces. And depending on their sizes, classic CNV can be classified as small, medium, and large. And occult CNV has been categorized as fibrovascular PED or late leakage of undetermined source. And late leakage of undetermined source type 2 lacks a discernible, well-demarcated area of leakage in the early angiographic frames. Speckled hyperfluorescence with no visible source becomes apparent 2 to 5 minutes after the dye injection. And RAP has been described and classified by Ennuzzi et al. In RAP, the vasogenic process originates in the retina and begins as intraretinal neovascularization, stage 1, which progresses to subretinal NV, stage 2, and finally to CNV, stage 3. In some cases, it's possible to find a retinal anastomosis. Angiographically, early lesions show a focal area of intraretinal hyperfluorescence with indistinct borders corresponding to the intraretinal neovascularization and surrounding intraretinal edema. In stage 2, it's very characteristic to find a serious PED with occult CNV associated to overlying cystoid macular edema. Although RPE tests can occur spontaneously, it is not uncommon for them to occur after treatment with thermal laser, PDT, or anti-angiogenic therapy. So this is where the complication, when patient asks, is there any complication, we have to tell them upfront. And RPE tears are commonly related to PEDs, although they have been described in classic lesions too. And the detached monolayer of RPE scrolls toward the CNV, leaving a denuded area of choroid exposed. On fluorescent angiography, the denuded area becomes hyperfluorescent and the scroll RP is dark and blocks the underlying fluorescence. Hemorrhagic AMD, FA is not very useful in hemorrhagic forms of macular degeneration since blood blocks the underlying fluorescence. A disciform scar is the end stage of a manifestation of untreated CNV, namely formed by fibroblasts and inflammatory cells. Angiographically typically shows late staining. And ICG angiography in ARMD is we know what it is, and then the importance of ICGA is identify the subtype of CNVM in AMD, the type 1, type 2, type 3, to differentiate ARMD lesions from simulating lesions. That's where the expert's opinion, apart from all this imaging. Hotspots visible in an area of exudation, PED with small CNV at the margin of the lesion. ICGA, only the vascular component of PED appears hyperfluorescent. And exudative AMD, plaque with poorly defined margins in the late phase, as you see in the picture A. And CNV has been reclassified as focal spots or hotspots, plaques or mixed forms, a combination of the first two forms. And you can, in the lower bottom picture, you can see two hotspots, the lower spot being more active. And CNV may be located at the margin of the lesion, marginal spot, above the lesion, overlying spot, or at a distance from the lesion, remote spot. And ICG angiography is very useful in these cases for establishing the presence or absence of associated neovascularization, since choroidal neovascular membrane may be masked by the hyperfluence of PED when the fluorescein is used. And if FFA proves inconclusive, ICG angiography may confirm the absence of neovascularization. And ICGA is very useful for diagnosing and classifying CNV associated to serous PED, distinguish between the serous and the vascular component. And classic CNV, which is better visualized with the FA in the early phases, since it masks the late phases by the hyperfluorescence of the entire lesion. And occult CNVM, where ICGA can show hotspots on the black image of the PED associated to RIP, the yellow arrows are the polyps with the red arrows. And this is a retinal angiomatous proliferation, and the retina image sources taken from our own Merante, from Ayatejot, and also from the AND2book.org and retina image bank from the ASRS. And so as a treasurer of the International Council of Ophthalmology, welcome you all to World Ophthalmology Congress on 16 to 19 in August 2024, Vancouver. And I'm also the president of Asia Pacific Ophthalmic Trauma Society, become a member of the most active society of the ophthalmic trauma, and where imaging is very important for pre-op, intra-op, and post-op. Thank you very much.
Thank you, sir, for those very important points that you have shown us. So I would now ask Darius, can you come here? If there are any, can you join us here, sir? If there's any question answers, if people want to ask anything on the wide field imaging, come. You have any questions?
This talk is the next one.
Oh, sorry. I thought, I'm so sorry. I'm so sorry. So there's the last talk by V. Prakash on interesting cases.